Hello guys, today we are going to deal with an important topic. The topic is from gynecology. The topic is endometriosis. Endometriosis. Right? Yes. Endometriosis is actually a very simple topic, but it has some key features which we have to know. Otherwise, we will be confused with this topic while reading gynecology. Okay, guys. So basically, I have got confused many times. But now, once again when I read this topic, I got many new findings, many new understandings. So that those understandings I want to share it with you. So come, guys. Let's directly go into the topic. So first, what is the definition? It's actually a very simple topic, but if we if we don't know the key features, it will be very confusing. While we read about endometrial cancers or many cancers, if we just keep on fibroids is there, so if we keep on reading about that, we will get confused about this endometriosis. So we should know the key points. Let's see what is it. Okay, first, what is the definition? Simple definition: endometrial tissue. Endometriosis is nothing but endometrial tissue. What is this endometrial tissue? Is nothing but glands plus stroma. Glands plus stroma. This endometrial tissue is present outside the uterine cavity. It's present outside the uterine cavity. This is endometriosis. Endometrial tissue which is present outside the uterine cavity is endometriosis. This condition is endometriosis, right? Yes. Okay. Next, what is the site? What is the site? Guys, the most common site. See guys, the most common site is first is ovary. The most common site is ovary, guys. Okay, the most common site is ovary. Then what are the next other common sites? That we will write it here. Right? What are the next common sites after ovary? See, ovary followed by pouch of Douglas. Okay, ovary followed by pouch of Douglas, followed by uterosacral ligament. Okay, followed by uterosacral ligament, followed by broad ligament, followed by fallopian tube. Okay guys, first one is ovary followed by pouch of Douglas, followed by uterosacral ligament, followed by broad ligament, followed by fallopian tube. Okay guys? Yes? Yes. But this only the you can ask me like are these the only sites where this endometriosis can occur, where this endometrial tissue can spread? No, there are other sites also. Okay, it can occur anywhere in the body. Literally it can occur can occur anywhere in the body. Anywhere in the body. Okay, like metaplasia. It's simply like metaplasia, but don't get confused. It is not a metaplasia or anything. It's just endometrial tissue outside the uterine cavity, right? Okay. So next is, which is the rarest site? That's an important question. Which is the rarest site. I'll use this bulletin there. Okay, which is the rarest site? Can occur anywhere in the body, but which is the rarest site? The rarest site is CNS, guys. The rarest site is CNS. Okay? Yes. Okay, next thing is, what are the other sites where it can occur? It can occur in scars of previous surgeries. It can occur in scars of previous surgeries. Right? So what are these? Okay, what are these? What are these called as? This is called as, just a second, I'll just erase the sun, right? This is scars, okay? Scars of previous surgeries. So what are these called as? This condition is called as scar endometriosis, okay? This condition is called as scar endometriosis. So what are the surgeries in which this endometriosis commonly occurs? That we have to know, right? So what are the surgeries? Can we just write it down? It is cesarean section. Next is episiotomy. Even in episiotomy it can occur, guys. Episiotomy, okay. Next is pelvic floor repair. Pelvic floor repair and myomectomy. Okay, cesarean section, episiotomy, pelvic floor repair and myomectomy. Okay, guys. So now let's just see this definition. We saw that it is endometrial tissue present outside the uterine cavity. Site is ovary. So what are the other sites? It's pouch of Douglas, uterosacral ligament, broad ligament and fallopian tube. But it can occur anywhere in the body. The rarest site is central nervous system, and it can also occur in scars of the previous surgeries, which is called scar endometriosis. And the common surgeries in which this scar endometriosis occurs is cesarean section, episiotomy, pelvic floor repair and myomectomy. Okay, now let's deal about the theories related to endometriosis. Okay, guys, let's deal about the theories related to endometriosis. Endometriosis. Okay. So what are the theories related to endometriosis? So the first theory is called as Sampson's theory of implantation. Just a second, guys. Sampson's theory of implantation. Okay. So what is this Sampson's theory of implantation? Let's see that. First of all, this theory is the most commonly accepted theory. We'll see another couple of theories after this, but this is the most commonly accepted theory, right? And what is this theory? This theory says this endometriosis occurs because of retrograde menstruation. Retrograde menstruation is backflow. Okay, so this theory states that this endometriosis occurs because of, so this is a theory of retrograde menstruation. Okay, guys. Yes, there is backflow. What is retrograde? It is backflow. Okay, this is Samson's theory of implantation. Number 2, let's go to number 2. Number 2 is Mayer and Ivanov. Mayer and Ivanov. What is their theory? Their theory suggests that theory of coelomic metaplasia. Theory of coelomic metaplasia. Okay, metaplasia. Right. This theory is also proposed, but we commonly don't call it as a metaplastic condition. You know, guys, there are many surgical conditions where you can see columnar to squamous to columnar transition and all, right? But this endometriosis is commonly not called as a metaplasia. That's why in the starting I said that endometriosis is not, though it is similar to a metaplasic condition, it is not called as a metaplasia, right? But Mayer and Ivanov suggested this theory of coelomic metaplasia, right? And there was a third theory. It was given by Halban. We'll also see one sign called as Halban sign. Okay, so let's see that. Let's see it. What is this theory? Theory of metastasis. Okay, he says that it is metastasis. He says that it is malignant. Endometrial tissue is malignant. He says like that. So he suggested the theory of metastasis, but as you know, the most commonly accepted theory is Samson's theory of implantation. Right? Okay, guys. Can we go to the next point? Let's see what are the risk factors and the protective factors. Okay, let's see what are the risk factors and protective factors. Okay, guys. Okay. So what will be the risk factors? Okay. First of all, the risk factors or protective factors. This is all is based on estrogen. Okay, this is based on estrogen. So in risk factors, there is excessive estrogen, and in protective factors, there is decrease in estrogen. Right. So this is mainly related to excessive estrogen. Right? This is related to excessive estrogen. So let's see what are the risk factors. First is risk factors. Risk factors. We'll write it here. First is obesity. Right, guys? First one is obesity. Second one is nulliparity. So if the female hasn't conceived, okay, it is nulliparous. So nulliparous is a risk factor. Third is early menarche and late menopause. Third one is early menarche and late menopause. Right? Fourth one is late marriage. Fourth one is late marriage and late childbirth. Okay, it is late marriage and late childbirth. Next, the fifth condition is socioeconomic status. What socioeconomic status? What we will commonly see is, what we commonly see in other conditions is low socioeconomic status, but here the socioeconomic status is high. So we see this in high socioeconomic status people, right? Yes. So next is, let's go to protective factors. I'll write it here itself. Protective factors. Okay. So what are the protective factors? Number one is multiparity. So multiparity. It is a protective factor. Second is pregnancy. It is a protective factor. Third is physical exercise. Physical exercise. Okay. Fourth one is smoking. So many times I used to think why this condition is mentioned. Though it might be a protective factor, it has a lot of side effects, right? So, but why this condition is still being mentioned in textbooks, and then it is asked even as questions? The main reason is this when you see a patient giving history of smoking, you can first rule out this endometriosis, right? When smoking is a protective factor for a few diseases, the first thing we have to do is, in patients with this history, we can rule out these conditions. Of course, we'll do other investigations, we'll look at other history, but we can also take this history as as a tool to eliminate eliminate the particular condition. For example, even in preeclampsia, the smoking is said to be a protective factor. So it is not that textbooks or science is encouraging us to do this. No, it is the thing. Why it is mentioned is we can easily rule out this condition. When a person says he's a chronic smoker or like that, we can rule out endometriosis in her, right? That's why this is being mentioned. Okay, so that's all about the protective factors. So can we go to the next topic? That is the next subheading. What is that is? What are the gene involved? Just a second, I'll add the new page. Yeah, new page. Yes. Okay, let's see what are the gene involved in it. See guys, the gene involved here is KRAS gene. Yes, it is KRAS gene. Next one is, what is the most common age? Ouch. What is the most common age? See, the most common age is more than equal to 30 years. Okay, it is more than equal to 30 years. Okay, next, endometriosis in puberty. When endometriosis is present in puberty, we have to also rule out one condition. Let's see what is that. See, just a second, I'll just change the color. Endometriosis, if it is present in puberty, it's most common in age 30 and above only, but if it is present in puberty, we have to rule out another condition. Rare cases can present at young ages, even younger ages, right? So if endometriosis is present in puberty, what we have to rule out? Please rule out Mullerian malformation, right? Please rule out Mullerian malformation. It's a differential diagnosis, right? Okay, when endometriosis is present in puberty, you have to rule out this anomalies, right? Mullerian malformation should be ruled out. Now we are going to the important part. What is the clinical presentation? We'll add another page also, another 2 to 3 pages. Yeah. Okay, so that it will be comfortable for us to write. Okay, so rule Mullerian malformation. Now, endometriosis clinical presentation. Just a second, guys. I'll just change the color. Very important, guys. Clinically, we should know to diagnose this endometriosis. Okay, endometriosis clinical presentation. Right? Okay, guys. So main thing what I understand as the purpose of learning medicine itself, it is to diagnose, it is to bring uh, what is it cure to patients with diseases. But for common, not for only common diseases, main aim is to find a cure for this undiagnosed diseases, right? Right? Which is very difficult to diagnose, for difficult to diagnose diseases, and for those diseases which doesn't have a treatment. Okay guys, so for that what we have to do is, first of all we should know a way to diagnose that condition. Okay, for many times I have seen patients where we in the time we find the diagnosis, the patient would already be facing his funeral, facing his or her funeral. Yes, we have seen many patients like that. So we'll just put any condition like sepsis or what is that, ARDS, we'll put that and we'll what is it, write it. But many a times, if we have diagnosed it quite early, we could have saved the patient, right? Yes, but it's not what is it, we cannot even blame the patients, because they come to us only when they present with symptoms, right? So they should also get this awareness, right? Anything, any small trouble, they should first come and refer to us. But what mainly I want to say is how to find this. See, there are guys biochemical investigations, ultrasound, radiological investigations, but main and profound thing is this clinical presentation. Our body constantly tries to communicate with us. Okay, body shows, communicates. Body communicates with us. If it has any trouble, this is a language, guys. This is a language. Medicine is not, I'll say, a subject. How to say it? It's not a just how to say, just a subject. It's like not just theory, bunch of theory stuff. It is a language, guys. So body tries to communicate to us. Okay, that to you. Your body tries to speak with you, speak with your mind. It tries to speak with your soul that there is some problem. Okay, sorry, my spelling is wrong. Here communicates, I have written. Just a second, guys. Oh, it's one line only. Okay, communicates. Okay, so what I want to say is, it tries to speak to us. So it says, I have pain. See, there is something wrong. Please come and what is it? Check, do an investigation, refer to the doctor. It speaks to us. But many times we forget, or we don't hear what our body says, right? So this clinical presentation, why I am saying this is, this clinical presentation, it's very, 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 very important. Very important. Even a small thing, guys, are just for I'm not delaying it, but still one particular thing is, even for glaucoma, I just read about that recently. Even for glaucoma, headache is an important symptom. For glaucoma, headache is an important symptom. You just imagine, when we get a headache, will we think we'll have glaucoma? Never, no. Only when retroorbital pain or some vision problems will go. But headache is an important symptom in glaucoma, right? So for those who are using gadgets, who are studying a lot, who are straining their eyes, see, headache is a warning sign. No, it's a warning sign. Glaucoma is a reversible condition provided we present early, right? But this condition presents with a so non-specific sign. Okay, it presents with such a non-specific sign, guys. See, so why I want to say this clinical presentation is so very important. So very important. Rather, I would say everything, whatever the subject specialty we are in, I'll say there is a medicine component, right? This clinical component is there. Right, that's why I want to say. So this endometriosis also has profound clinical presentation, guys. Profound clinical presentation that we are going to deal. So just there's one famous proverb. I'll just say that and I'll move on to the clinical presentation. What the mind doesn't know, the eyes cannot see. Okay, just take a screenshot or remember this proverb, guys. What the mind, I don't know who said this or not, but I just like to say this. What the mind doesn't know, the eyes cannot see, guys. Right before us, even a patient can be gasping. But only when we know this is gasping, we can treat the patient. So diagnosis is everything. Diagnosis is everything. Right? So for that, this clinical presentation is very important. We can say that medicine is simply clinicology. I'll just give a new term like that, clinicology. Why? Because it's completely practical. So very practical. Even if some one of our family members get, we should know to diagnose. We should know to diagnose. This week I'll be speaking for the whole day, but still I want to say this, right? Okay, guys. So early diagnosis. Many diseases could be prevented by this. Okay, guys. Can you go to the clinical presentation? Yes. Endometriosis clinical presentation. There are 4 symptoms, guys. Four symptoms. 4 symptoms which you have to remember. What are they? First, the most common symptom is pain. Yes. The most common symptom that you are living is, you should know that there is pain. Yes. So most common symptom of endometriosis also is pain only. Like second most common. What is it? What is the second most common is infertility. Right. Third most common is endometrioma. What is endometrioma? Also called as, endometrioma. It is also called as chocolate cyst of ovary. Chocolate cyst of ovary. Right? Next, chocolate cyst of ovary. It's present in ovary. Can write it as chocolate cyst in ovary. That will be good. Okay, chocolate cyst in ovary. Fourth most common symptom is menstrual symptoms. What is it? It is menstrual symptoms. Okay, guys. Right? These are the 4 common symptoms. Yes. Now, we can deal about this in detail, or I'll just write the treatment of each one. Okay. So these are the 4 common symptoms. So for pain, what is given, how to treat, and for infertility, what is given. There is mild, moderate, severe, and all. So it will be quite extensive. So I'll just cut short it. What is the management for pain? I'll just write this. Okay, for the symptoms only. Okay, there is some one triad also. We'll be dealing about that, but and of course about the endometriosis investigations also will be dealing about that. But cutting short, I'll just go for how will you manage this symptoms. So management of symptoms. What is it? First, for pain, for mild and moderate, what we will give is, for mild and moderate, we will give NSAID and OCP, right? For severe, moderate or severe, what we will give is progesterone. It is given. There is fourth generation progesterones like norgestimate, and there's another called gestrinone and all is there. So, but basically progesterone, which is the cheapest thing, and GnRH is there. GnRH, guys, if you have to deal in detail, it will take a lot of time. So I'm just saying, when GnRH is given in a pulsatile manner, it increases LH and FSH. Okay, but when it is given in a continuous manner, it decreases LH and FSH. Okay, remember this. Our own body secretes in a pulsatile manner, but when we give in an alternate way, that is when we give it continuously, it decreases LH and FSH. Okay. Another thing is, what we give is mifepristone. We give letrozole. We give letrozole, which is an aromatase inhibitor. This is also the drug for PCOS. Okay, and we give mifepristone. You know what is another name for mifepristone? Hope everyone will know. That is RU486. Why we would have studied about that in MTP and all, right? Next is infertility. I'm just cutting it short. Just management. Okay, I'll just say about it. So for mild infertility, what we'll give is clomiphene citrate. For mild infertility, what we'll give is clomiphene citrate. What is clomiphene citrate, guys? Ovulation induction drug, yes. Inducing drug, yes. What is it? Have you heard about SERM? Selective estrogen receptor modulator? Yes, it is that. And for them, we can do IUI. What is IUI? Intrauterine insemination. For moderate and severe cases, what we have to do? Moderate and severe, what we have to do? Directly go for IVF, in vitro fertilization. Yes, next, third one. Yes, third one. This is the second one, no? Third one, is chocolate cyst, right? Third one is chocolate cyst, that is endometrioma. Okay, so endometrioma, what is the management only you are saying? This definitive management is laparoscopic surgery, guys. Laparoscopic surgery. So if it is less than 3 centimeter, we do laparoscopic electrocoagulation. Okay, lap electrocoagulation. Whereas if it is more than 3 centimeter, we do lap cystectomy. Just remember this, guys. Okay. Next, fourth is, what is the fourth? It is menstrual symptoms, right? Fourth one is menstrual symptoms. Mainly menorrhagia is present. Symptoms. Writing it fast so that we cover it within time. Okay, so it's menorrhagia. Okay, that's what occurs. So basically, what can we do? Already we have given, no, for menstrual symptoms, given progesterone, right? We're given progesterone because there is progesterone maintains it. So progesterone can be given. So there is one triad which we can just remember. We know already there are 4 symptoms, right? One common triad which is said is clinical triad. It's a clinical triad. It is a clinical, I'll just write it in, just a second, I'll write it in different color. It is a clinical triad, guys. Clinical, that's important, that's why I'm writing. What is it? It is secondary dysmenorrhea, infertility, and dyspareunia. That's pain during coitus. It's infertility, dysmenorrhea also, Right, so secondary dysmenorrhea, infertility, dyspareunia. Right? Okay? Yes guys, and another, in PV you can see something. Pervaginum examination, you can see that there will be a retroverted uterus and there will be cobblestone appearance. Cobblestone appearance, you already know, it will be in inflammatory bowel disease, IBD. There will be cobblestone disease. That is cobblestone appearance. Right? But here also you see something called as cobblestone appearance. Okay guys, now we will go to endometriosis investigations. So investigations, what are we going to do? The investigations is quite a lot, but there's a sequence how we should do this investigation. See guys, the first investigation which we are going to do is the first investigation is do a TVS. TVS is transvaginal sonogram, right? Do a TVS, that is transvaginal sonography or sonogram, you can say that. Okay, next, what you have to do? So followed by, even before the result, seeing the the further investigations, you have to start her with empirical therapy. Okay, start her with empirical therapy. Right, now what you have to do is investigation of choice. There is investigation of choice. Okay, so only when this empirical therapy is basically medical management. So when you start with empirical therapy, but it is not the pain and the symptoms are not relieving, what you do is you do laparotomy to confirm the diagnosis plus treatment of the pain surgically. Once you do lab, that is by what? It's laparoscopy. Okay, laparotomy you do and confirm diagnosis, then automatically you deal it with surgery. So that is a laparoscopic surgery, right? This laparoscopic surgery, this is, or you can say laparoscopy itself, this is the IOC, that is investigation of choice. Okay, now these terms I really hate. Why? Because it confuses us many times. See, there is something called as gold standard, there is something called as best, and there is something called as investigation of choice. This should not confuse us. I also have got confused many times, but now I think you have to, when you prioritize, what is the investigation of choice? One test which you do to confirm diagnosis, laparoscopy. That's all. Laparoscopy, you say endometriosis is done. That is the term. But starting it was very confusing, but now we can know. I really understood that. But when you hear for the first time, don't get confused. Investigation of choice is one investigation. If they say there are a lot of investigations, it's inconclusive, you say, okay, we'll do this. This investigation, we can confirm it. That investigation is laparoscopy, right? In endometriosis, I am saying. So in that you see, there are many important things we have to say. I'll just show that with pictures, okay, at the end. But after, what is the protocol? Let's first see the protocol. Plus, if this laparotomic surgery, okay, after laparotomy, what you do is, treatment of pain surgically, okay, that we do. So that is the investigation of choice. But what is the best management? they'll ask, what is, if they ask what is the best management, what is it? It is, best management is medical management. Does anyone want to get surgery at the first treatment? No. Everyone wants to get cured by taking drugs, right? So the best management is medical management only, right? Okay, guys? Yes. So this is the thing. So in medical management, when there is mild pain, as I said before, we give NSAIDs plus OCPs. It fails means we give progesterone or we give GnRH, agonist or antagonist. In GnRH we give agonist or antagonist. Then finally we do laparoscopy. Okay. So this is the thing, guys. See, guys, after this, after doing laparoscopy, we do a test. What is that? It is HPE. What is this HPE? Histopathological examination, which is the gold standard. Okay, it is a gold standard investigation. And also note that CA 125 levels will be increased in endometriosis. Okay, guys, CA 125 level will be increased in endometriosis. Okay. Okay, guys, so now we'll just see this laparoscopic images, right? Just see the laparoscopic images. Yes, guys, this image is taken from the New England Journal, right? Let's just discuss this. See, ovary, you know that will be chocolate cyst. Okay, so I'll just mark with laser. Ovary, see the ovary, there will be chocolate cyst, right? Okay, the chocolate cyst, if you know, it will be like in transvaginal sonography, it will be like ground glass appearance. In transvaginal sonography, here you can see that it is dark in color, right? It will be dark in color. Okay, mainly I remember it as it is because of hemosiderin chocolate cyst. Okay, so just please do refer it in to textbooks like Shaw and Data. That's a common textbooks which I use. Okay, if you are able to access Williams, it will also be good. So I think it's basically due to hemosiderin, this chocolate cyst. Please just refer that, guys, that point alone, right? And in peritoneum there will be quite a lot of lesions. I think it's named here itself. Yes, I'll just write it, guys. See, what are the important peritoneum findings? In ovary, you will see chocolate cyst, right? You will see chocolate cyst. In peritoneum, you will find, see, in peritoneum, you will find powder burn. I'll just write it in different color. See, it will be powder burn, guys. Powder burn or gunshot appearance. Gunshot appearance, right, guys? It will be small blue black lesions, small blue black cystic lesions, cystic lesions. Okay, I'll just show that in diagram. Next, there will be red cystic lesions, and there will be white scarry lesions. Just a second, I'll just, there will be, okay, guys, there will be white scarry lesions, right? Because you can, because scar endometriosis can also occur in this, right? So there will be white scarry lesions. And there is one syndrome which will occur here, that is Allen-Master syndrome. Allen-Master syndrome, which is basically nothing but peritoneal defects. Peritoneal defects, guys. So this is what I'd like to say to you about investigations, right, guys? So what is the treatment? Yes, I said about the treatment, right? Medical management, simple medical management, NSAIDs, OCPs, progesterone that you give. And next is, if it fails means you do laparotomy. Okay. See, investigations this. Treatment, I have have I written it? If not, I'll just write it separately for you to just not get confused. Yes, treatment, I'll write it here itself. It's just short part. Treatment is very simple only. What is this? To treat dysmenorrhea and all, we give NSAID plus OCP. Okay guys, if it fails, we go to progesterone. There is 3rd generation, 4th generation progesterones like gestrinone. If not, you give GnRH, agonist or antagonist. This is G, don't mistake me. It is G guys. Antagonist. Followed by, if it fails, final gold standard is, don't get confused, this is for treatment I am saying. Gold standard is HPE only. Okay, histopathical examination. But I am saying for treatment is laparoscopy. Laparoscopy. Right? Laparoscopy. Right? Okay guys. So that's the thing. Okay, hope it is clear. So just, can we have a brief revision at the end? See guys, just a brief revision. Oh sorry, see here. This, when did this blue come? This didn't see this. Okay, so okay guys. Okay, just right. What to do? It's returning eye. Okay. Just a second. Laparoscopic. Okay. See, like this only it comes. Okay. Yeah, just a second guys. I will use this. Now I can turn it. Okay guys, can you see this? Yes. See guys, endometriosis. So this is a brief summary, quick summary. Within 2 minutes you'll just complete this. See, endometriosis, what is this? This is endometrial tissue which is present outside the uterine cavity. Endometrium should be present inside the uterus, but it is present outside the uterine cavity. Next, the most common site is ovary. Ovary, more than pouch of Douglas, followed by uterosacral ligament, followed by broad ligament, followed by fallopian tube. Can occur anywhere in the body. Okay, it can also occur anywhere in the body, and the rarest site is brain and spinal cord. Next, it can also occur in scars of the previous surgeries, which is called scar endometriosis. And cesarean section, it can arise from cesarean section, episiotomy, pelvic floor repair, and myomectomy. What are the theories? Samson's theory of implantation, which is the most commonly accepted theory, retrograde menstruation. Mayer and Ivanov gave that it is because of coelomic metaplasia, and Halban gave that there is a theory of metastasis. Right guys? Yes. So I was saying about this Halban, no? It will usually occur in adenomyosis. Halban sign is nothing, there is a sign called as Halban sign, which is nothing but tender uterus. Tender uterus, another differential diagnosis, what do you remember? Abruptio, right? It also presents the tender uterus. Just remember it. Halban sign will come in adenomyosis, but Halban only gave the theory for endometriosis, there is metastasis. The risk factors and protective factors we saw, it is obesity in early menarche, late menopause, late marriage and late childbirth, high socioeconomic status. And what are the protective factors is multiparty pregnancy, physical exercise, smoking. Smoking is not advised, it's just for ruling out the differential diagnosis. Gene involved, KRAS, most common age is more than equal to 30 years, endometriosis in puberty. When it presents in puberty, you have to rule out mullerian malformation. So the clinical presentation, which is the most important thing, most common symptoms are 4. What are they? The most common symptom is pain, Second most common is infertility. Third is endometrioma, chocolate cyst novelty. Fourth is menstrual symptoms. Okay, so for pain, what you give? NSAID, OCP. If it's severe, moderate to severe, we give progesterone, GnRH, continuous letrozole. Continuous GnRH will decrease LH and FSH, whereas pulsatile will increase LH FSH. Remember that. Next, letrozole, which is what is letrozole? Anyone? Aromatase inhibitor, right? Next, mifepristone, Ru486. Infertility, we give clomiphene citrate, which is SCRM, right? Clomiphene citrate. Next, we do IUI for mild infertility. For moderate severe, we do IVF. Endometrioma, we do laparoscopic surgery. When it is less than 3 cm, we do laparoscopic electrocoagulation. Whereas when it is more than 3, we do laparoscopic cystectomy. Okay guys, clear? We do laparoscopic cystectomy. Next, we remove the cyst. Menstrual symptoms, what mainly we will give is progesterone. We will just control with that itself. OCP will regularize the cycle, or else you can also give OCP, which will regularize. See, just a second. See, OCP will regularize the cycles. Okay, you can also give OCP. I'll just write it here. OCP is OCP is progesterone. Right, that's a clinical triad. Secondary dysmenorrhea, infertility, and dyspareunia. Vaginal examination, we can see the retroverted uses and cobblestone appearance. Investigations, how will you proceed? First investigation, transvaginal sonogram. Okay, during that time itself, whatever be the findings, except unless otherwise it is normal, you have to give it, you have to start the treatment. If it's suspicious or it is diagnosed, you have to start with empirical therapy, right? Only when it's normal, no need to start with antibiotics. Understood guys? Next, transvaginal sonogram followed by laparotomy to confirm diagnosis, plus treatment of pain surgically. Okay, laparoscopy is an investigation of choice, whereas gold standard is histopathological examination. You know that CA125 levels will be increasing endometriosis. See that medical management, what we have written here, for that what we will give? NSAID plus OCPs. If it fails, we will give progesterone. If it fails, we give GnRH agonist and agonist. If it fails, we do laparoscopic, right? Laparoscopic surgery. Right guys? So you can see the signs here. See here. Here you can see the red lesion. Right? You can see here adhesions here. See? That is blue-black lesion. What is this? This is a powdery or gunshot appearance. Okay, see. I'll just zoom it. See. Okay, this image is available in New England Journal. Okay. Next, you can see that ovary endometrioma, chocolate cyst. So, ovary presents with chocolate cyst, peritoneum powder burn or gunshot appearance, which is nothing but small blue-black cystic lesions. Next, red cystic lesions, white scary lesions, and Allen-Masters syndrome, okay, which is nothing but peritoneal defects. So that's all for today, guys. Of course, I just want to say this. The source I read from textbook, but also I used, I don't want to name it, but I used on online source also to learn about this. Right guys, so I mainly understood many things from that, so I just wanted to share that also, but it is extensively given in textbook, and learn from that also from Shaw's textbook and datas. Okay, of course if you find useful, you can use those also. I hope this video is useful to you. So thank you guys, thank you, and have a good day.